MCHC is a hospital association. It is a hospital healthcare association. We have over 94 hospitals in the Metro Chicago area. We have 150 members overall, with associate members, including hospitals that are outside the metro area, going up to Kankakee, Wisconsin, areas of Indiana, as well as some long-term facilities. So with the broadband initiative funding, what we've been really working with is trying to set up a pilot for telepsychiatry. If we think about all the issues that have happened in the last few years in the state budget, there have been a lot of state reductions in funding for mental health care, both on the outpatient level and on the inpatient side. So what that has meant is there have been a large number of behavioral health patients who are presenting to emergency departments in really emotional distress. Right? They're either dangerous to themselves or dangerous to others. But because of the lack of outpatient funding, they're unable to get care on the outpatient side. Quite often they're not on the correct meds or on any medication at this point. Because of the cuts in funding on the inpatient side, we have difficulty placing them from the ER if they need to be admitted. So these patients often will have a very long length of stay, meaning they'll be in the emergency department for 3, 4, 5 days. And certainly if they weren't psychotic, by the time they got there, after 4 days in an ER, 24/7 being awake, you can imagine what that could do to someone. As emergency physicians, we're very good at keeping people sedated so that they maybe not as much of a danger to themselves or to the staff. But it's really, we're not trained, as well as psychiatrists are, to start them on the right medication for stabilization. So if we think of video as a way of bringing in psychiatrists, psychiatrists can do an interview, they can do a consult, they can start the patient on the right medication, and then hasten the patient's ability to be stabilized. Right? So they can either potentially be discharged if their symptoms get better with the correct medications, or if they do end up being admitted, their length of stay on the admission side is going to be shorter because they've already started their treatment. It's going to save money all the way around. So when we think of new programs in terms of healthcare, we usually measure them on quality, access to care, and efficiency to care. So right now, with access to care, psychiatrists aren't present in emergency departments, and for some rural hospitals, they may not be present for hundreds of miles. So certainly you can see with this, access to care goes up. Only efficiency to care. Being able to get care, being able to get it quickly, goes up with this type of technology. And all that is going to lead to a higher quality of care. So with the funding that we've received, what we are doing now is we are going to connect mental health providers who are skilled in telemedicine with 3 to 4 or 2 to 4 rural hospitals who don't have access to these services. And we're going to see how many patients we can take care of between now and the end of the grant period. What is their difference in the length of stay? What is the difference in their outcomes? So we're really actually going to measure it just like any other sort of research grant. And then after that, we are really going to work to transition the providers that we've chosen to work into a sustainable business model. Telepsychiatrists will provide care in return for a fee from the hospitals. And the hospitals, in turn, will be able to bill the insurance companies for the psychiatrist. And we've really hit a crisis state in terms of behavioral health patients in the emergency department. So you can imagine if you have an emergency department with 16 beds, and 4 of those beds are taken up by mental health patients, you've lost your throughput of 25% of your throughput. So people have to wait in the ER longer. Well, what happens if you have someone with abdominal pain who has a brewing appendicitis? They can't get a bed because these mental health patients are there. They have to wait in your ER. Their outcomes are going to be worse. Right? So we know that by having these patients taking up the space, the overall health of anybody who presents, whether it's from a behavioral health standpoint or a medical or surgical standpoint, is going to be impacted. Any of these pilot projects, what we tend to think of them as is venture capital for the public good. Right? If we can turn them into a sustainable product, which improves the health of patients, improves the quality, the efficiency, and the access to care, we as a society, we're all better. So while these grants in themselves don't pay for anything, by leveraging the resources that we have, our ability to convene people, we think we can turn it into something that will be sustainable and will continue to grow, not just this year, but several years down the road. Obviously, this technology depends on broadband, and it needs really high definition video. Whatever the subspecialty is that you're going to work with. I'll give some examples that we've worked with before. Is American Sign Language. Right? So if your video hangs, if your video has a lot of trails, the patient who needs the interpretation won't be able to read it. If you are looking at telestroke, it can't. Again, it has to be crystal clear because you're really looking at any sort of inflection, change in voice. You're looking at a change in the musculature of the face, of how the hands work. And that has to be really crisp, clear, continuous video that doesn't jerk, that doesn't hang, that doesn't have a trail. So that can only be done through broadband.